First, I want to acknowledge the land on which I find myself on today. Given that we're online, we're all in unique locations with unique stories and histories. But myself, I'm in Montreal, where the Ginenean-Gahaga Nation is recognized as the custodians of the lands and waters. Geojahage, Montreal, is historically known as a gathering place for many First Nations. Today, it is home to a diverse population of Indigenous and other peoples. We respect the continued connections with the past, present, and future in our ongoing relationships with Indigenous and other peoples within the Montreal community. Bette Watson-Borg is the project manager for clinical guidelines for social isolation and loneliness in older adults at the Canadian Coalition for Seniors' Mental Health. She brings over 30 years of experience working on programs, projects, and social impact initiatives related to health and well-being of people and communities. She is passionate about collaborating across sectors to act together, resulting in new solutions for social change. In this project, she has the good fortune to work with a dedicated and knowledgeable working group of healthcare and social service professionals, academic researchers, and community-based serving organizations from across Canada. And I'll hand it over to you, Bette, to take it from here.
Great. Thank you so much, Erica. And thanks everybody for joining us this morning. My name, as mentioned, is Bette Watson-Borg, and I'm joining you from quite overcast Nova Scotia. But as I look out my window, I can see a little bit of blue sky coming. So it's a pleasure to be with you. And prior to my living in Nova Scotia, I was in the Brockville area. So I spent many lovely times crossing the border into beautiful Quebec. Great memories of what you have in Quebec. So thank you for this invitation. So let me get started. You've heard a little bit about who I am and who I am representing today with the Canadian Coalition for Seniors' Mental Health. With our time that we have today, we'll be spending a little bit of time sharing information about the backdrop and the context of social isolation and loneliness in older adults, bringing to you information that you may already know, and there may be some nuggets that are new for you. Then I'll be moving into the specifics of the project that we're working on that's respect to developing clinical guidelines for healthcare and social service professionals in this area of social isolation and loneliness, and then sharing a little bit about what's happening globally. So a couple setting some context. If you haven't heard of the Canadian Coalition for Seniors' Mental Health, which I will start to refer to as CCSMH, rolls off the tongue, the organization is passionate about promoting the mental health of seniors by connecting people, connecting ideas, and connecting resources, including a great deal of research. And where this comes from is from a philosophy that mental illness is not a normal part of aging. All seniors have the right and deserve to receive services and care that promote their mental health and responds to their needs. So CCMH is hard at work working to support and advocate and carry forward research and share information about this really important health issue. A little bit about the background of CCSMH, I say it rolls off the tongue, but sometimes I stumble with it, is actually over 20 years ago, another organization called the Canadian Association of Geriatric Psychiatry, which was, as it sounds like, a group of geriatric psychiatrists that got together for professional development. They began to think this topic of mental health in older adults is so diverse, we need to be tapping into the resources and knowledge of other professionals. So decided to create an adjunct organization called CCSMH, and that involves every and any other profession that is interested in mental health and older adults. So it involves academics, it involves clinicians, it involves staying connected with the communities that are on the ground locally and staying at the forefront of emerging knowledge. And it's a small organization. And so where we focus our energy really is around researching and writing, sharing and mobilizing clinical guidelines for healthcare and social service providers so that they can support the health needs of their patients or their clients who are older adults. So where did this sort of come from? And I don't think this will be a surprise for anybody in this room. Prior to the pandemic period in 2019, Angus Reid, which is a national pollster, surveyed and found that 48% of Canadians were reporting themselves as being socially isolated, lonely, or both. This was pre-pandemic. So, without question, we know that the pandemic really brought this topic to life. It came into our homes, came into our communities, and pretty much affected everybody in Canada and everyone on the planet. So, this is probably not a surprise for you, but to say that this kind of information was starting to be looked at and coming out prior to the pandemic. And interestingly enough, this Harvard study of adult development, which has been going on for several decades now, it is finding and continues to find that close relationships, more than money or fame, are what keeps people happy throughout their life. And that those relationship ties really help to delay mental and physical decline. And they are actually very good predictors of long and happy lives, even better than social class, IQ, or even genes. So, just a quick revisit of the initial test or questions and looking at the results, this group that I have the good fortune to be in front of are extremely knowledgeable. So yes, socialization, this is one of the definitions, and we'll be looking at a little bit more in a second, can be defined as a measurable lack of social contact. So it's something that's fairly objective, and you can sort of count it in numbers. Whereas loneliness can be defined as a personal feeling. So it's a very much more subjective and personal feeling or perception of feeling alone or isolated. And person can be socially isolated and not experience feelings of loneliness. So that feeling that you can be a person that loves to be in nature, loves to be walking through the woods, loves to be walking through quiet places, and it actually is what feeds you and it helps you thrive. So there is that feeling that you can be all by yourself and alone and not experience feelings of loneliness. There are a number of different resources and sources that uh, be have been defining these two words. So I want to start off by saying that these are two words. They get put together a lot. In our current project, we are putting them together a lot. But the recognition is that they are different words, they have different meanings, and future research is really wanting to explore each of those words on their own. But at the same time, they are very closely related and impact each other. So, all to say in summary, it's really, really complex. So, you can see on the left side, social isolation, it's that measurable in the number of social contacts or relationship a person has, whereas loneliness is that thing that we feel it in our heart, we feel it in our gut, we feel it in our bodies, that just says the quality and quantity of the relationships or contacts I'm having aren't where I would like them to be or that I wish they would be. So appreciating that loneliness is a very individual thing. So when we start to look at measuring it, it's a really complex approach. In the middle, though, we have a couple other things where these two words start to come together. So the evidence is showing that social isolation, too much social isolation, or the not right type of connections can increase the risk of loneliness. But we also know that more social contact does not automatically reduce loneliness. That feeling of you can feel lonely in a crowd. And thirdly, the quality of social relationships is also important, as well as how people feel about those connections. It's sort of that idea, having one relationship that you feel is a quality, feels good, can mean a lot more to someone than potentially having 10 social contacts that aren't of the quality. So, in summary, two different words, unique meanings. They have the potential to impact each other, and there is a lot more work that's needed to understand the impact of both of those on the health and well being of older adults. This slide shares with you a little bit of a deeper dive of the different types of loneliness, and you can see the citations that we have social loneliness. Where's that perception? I feel lonely and I don't have the relationships I would like or wish to have. The emotional of having some deeper connections with people, And then the existential, a feeling about how do I feel about loneliness in the context of my humanness. And you can see one of those resources go back to 1961. So although I'm saying there's a lot of learning that's going on right now, there's been a fair bit of research in these areas over the last number of decades. Moving to our focus today of some reasons why older adults are at increased risk of experiencing social isolation. And this graphic is taken out of from the National Seniors Council, and it's actually in a report from the National Institute of Aging, which comes out of the Ontario context. So I won't go through all of these, but we'll just take a moment to walk ourselves around the wheel, and we can start to see that there are a number of different things that are, some of them that are controllable and some of them that are not, such as age, age. All right. We'll talk a little bit more about these, but you can see at a glance that there are many different things that can actually impact the how older adults might be experiencing social isolation. And one of those facts of life, as we age, we do face life transitions. In fact, probably from the moment we come into this world, we face life transitions, and that can contribute or may contribute to the risk of becoming socially isolated or lonely. So as we look at that topic of life transitions, we wanted to highlight for you today, and much of this may not be a surprise for you. Some of it may be new for you, and some of it may give some pause for reflection, which is what we hope can happen today. So, some of the life transitions that the research has shown us is um, that these things do happen, and they can impact our social connections, and it can change them, and it can also impact how we're feeling about loneliness, the quality of the relationship. So, word cloud, because they're all possible. There's not one that's more important. There's not one that's more obvious or more relevant. But these are all the different things. So, as we look at if we look at retirement, which would be sort of the early older adult, that idea that our working lives are important and they can define who we are, how we see ourselves, how we spend our time, and the relationships that we have. So retirement can be a time where people are finding significant change. So uh, reflection is what might we do in anticipation of retirement to start to anticipate some of those things and think about what might be some things we could put in place before retirement is upon us. Other areas are the loss of friends or family through the death or a change of marital status or partner status. Uh, Other things that can include things could be a change in where we live. So we could be moving from one place to another. We could be moving from one community to another. So just the place where we live can be something that can impact our our connections and how we're feeling. And then the other thing that relates to the health changes as we get older, the change in our vision, not necessarily loss of vision, but even change of vision can make a difference to our feeling of safety when we're going out, or our ability to actually see and read things that might be important when we're going out and about. And as we think about equity and health equity, that there are those in our country who do not have the resources to access glasses. So that's where we start to look at some of our communities that may be facing different experiences from some of these health inequities, such as who can access glasses and who cannot. Changing in mobility, that feeling of not feeling as comfortable or safe going out when it's icy out there, whereas in the summer it may feel a little bit different. And the other one on health there was loss of vision, limited mobility. Oh, another one that we don't actually have listed here would be incontinence. As our bodies change and our ability to hold our bladder, that's another thing that can actually affect us in terms of our comfort in getting out and about. And something one of our working group members mentioned that I hadn't actually thought about was nutrition and diet. So someone who has lived with celiac disease all their life, that could be, and it's getting worse for them. That feeling of being not being able to go out socially and eat. So all to say, there are a lot of different things that we want to be mindful of and be thinking about, and not because we can necessarily change these things, but just to be aware and okay that okay, this might be affecting my comfort level in getting out and about, meeting with people, socializing, even going for a walk if it's icy outside. And so, that being said, just to recognize that we can all feel lonely sometimes. It's part of that human condition. It's part of the beauty and wonderment of our our emotional systems. However, that feeling that if it goes on for too long, or that the intensity of is changing and feeling more difficult for us, it can ultimately have impacts on our health and our well-being. Based on the excellent results from the first survey that we did today and how well informed people were about social isolation and loneliness, one of the things that we've been asking as we've gone out and talked to people is the awareness of the impacts of social isolation and loneliness on the physical and the mental. Anticipating many of us came out through the pandemic being a heightened awareness of the mental impacts of too much time alone, not being able to see the people that we know and love or are interested in spending time with. Interesting though, the research that's been coming out probably in the last 5 to 10 years now is really starting to highlight both the not only the mental health impacts, but the physical impacts. And so this is again another summary from the National Institute of Aging report, which is a phenomenal, really accessible report that you might find interesting. And they do some great infographics like this. So you can sort of see the different kinds of things that physically can happen to us if we find ourselves in that really prolonged or intense times of feeling disconnected. Stroke, heart disease, cancer, dementia, um, functional decline, and increased risk of death. So our intention, my intention today is not to just add all these worries to everyone. It's more about raising awareness that, you know what, as we get older, there are life circumstances that are part of being human and part of aging. And there's some things here that maybe we didn't know and maybe we want to think about. And I think what this slide really describes is the miracle of the human system and how interrelated the mental health, the physical health, the emotional health, the social health, they all work together. Now, on to take another look at this same topic from a slightly different side and evidence-based as well, is what about solitude? And often solitude and being alone and being ourselves and being comfortable in our own company are things that kind of come together. This paper on 7 science-backed reasons you should spend more time alone is actually giving us some more information about the value of spending time alone. And I think in a way helps to combat maybe some of the social pressures or stigma about being alone. And so this is a short list of the kinds of things that science is demonstrating by spending time in our own company. Increased empathy, increased productivity, sparks creativity, helps build our mental strength. It's an opportunity to pause and reflect and to think about what's ahead. It's being demonstrated. It's good and great for children. And spending time with ourselves helps us to know ourselves. So there's a little check mark there for the other side of spending time alone. The social determinants of health, which is this beautiful, colorful wheel, have been around formally in the literature and used actively in community are called the core determinants or the social determinants of health. And so you can look around the wheel and you can see all the different things and you can actually, if you think back to that slide a few slides ago around the different risk factors for older adults and loneliness, there's lots of parallels here. But what I thought would be interesting is if we think about social isolation and loneliness And how do these different social determinants influence or impact, or how are they related? I thought, well, for sure, social environments, there's one. So I put a yellow arrow there. I thought, okay, social environments for sure, there's one. And then I thought, oh, social support networks, there's another one. Oh, then I thought physical environments, having accessible environments where people can get in without feeling like they're going to slip or fall. There's another one. And so by the time I did this, I had thought there would just be a couple of the social determinants of health that directly tied with our topic of social isolation and loneliness. But as I looked at it, absolutely every one of the social determinants are influencing and impacting social isolation and loneliness, which tells me, and which I share with you as my thought, is that by continuing for our healthcare, our social systems, and for our own actions and reflections, is that we really want to continue to pay attention to the social determinants of health, because every single one of them will be a positive impact and influence on the social isolation and loneliness factor. So, all in all, I don't think we need to add social isolation and loneliness as a social determinant of health. I think we just continue to integrate it and keep them connected with each of the ones that have already been demonstrated. As we look at, I've been using the term older adults quite freely and liberally. And we also need to recognize is that with older adults, everybody has their own definition of what that is, what it looks like, when it starts, et cetera. But we do recognize that each cohort, if we, even, you know, 50 to 60, 60 to 65, quote retirement, 65 to 70, and then 70 to 80, et cetera. Each one of the cohorts of older adults do have unique interests, unique needs, come from different like historical backgrounds, how we grew up, when we grew up, what were the influences, et cetera. So all to say that I don't do service to the diversity of older adults and their experiences in this area, because everyone has an individual experience, and even with those age cohorts, there are going to be some unique contributors. And that being said, I'd also want to draw attention to within those cohorts, within the population of older adults, there are marginalized communities that are at higher risk of feeling those health impacts, the mental health, physical impacts of social isolation and loneliness, and primarily because they do face, the evidence have showed it, the lived experience and their testimonies tell us that they face health and healthcare inequities. And so it's mindful that our healthcare system and our communities do work to try to reduce or eliminate those health inequities. Indigenous seniors are one of those communities at higher risk. It says marginalized U.S. communities, but I think we can make that translation to Canadian and pretty much every country that Hispanic, Black, immigrant, and to us LGBTQ plus individuals have been, it's very clear that they face inequities in health, and more is needed to pay attention to how we can support them, not only in their general health, but in this topic of social isolation and loneliness. We've tried to provide a few resources on our slide deck. This Loneliness Science and Practice is an excellent article. And this paper, although generated by the Government of Canada, was done in close partnership with Indigenous community organizations and community. And it's social isolation of seniors with a focus on Indigenous seniors in Canada. So there's some excellent information and background and resources there. And as I mentioned, to us LGBTQI plus older adults in Canada also face significant health inequities and different health inequities than they might have experienced when they were younger and growing up. And this report is hot off the press, August 2023. So again, a really excellent resource created and researched and shared that you might find interesting. So I'm kind of closing out on my background of background of this big complex topic, and really just the tiny tip of the iceberg, but hopefully we're getting warmed up and you're getting a little bit more into some of the background and risks and opportunities. So now I'm going to turn it more to getting prepped for the clinical guidelines on social isolation and loneliness in older adults that CCSMH has been working on. And I'm starting with like why bother? And I share with you this quote. Julianne Holt Lundstedt published in this year, 2023, in the New England Journal of Medicine, which is a pretty well-respected journal in the clinical field. And she says, and in this one case I'll quote, social isolation and loneliness are rarely listed on death certificates, yet they may be contributed to the excess deaths from all causes observed during the pandemic. Although the health sector cannot solve this problem alone, the medical community does need to respond. Clinicians will require adequate training, resources, and support so they can integrate screening, interventions, and referrals for social isolation and loneliness into their existing responsibilities. Patients' lives may hang in the balance. So what we were underway on our project, and however, when this research came out, it was really almost like solidifying how important it is that we all start to look at the important role that healthcare and social service professionals might be able to play in new ways, in different ways, as we look at this growing challenge and health challenge of social isolation and loneliness. And what was interesting about her article is that she started doing this research because of the personal experience she had in the pandemic with her parents. And so it came from a place of a personal experience, and then she's an awesome researcher and went off and did some great writing, research and writing. So I encourage you to take a look at that. The other the other quote I'd like to share with you is the opportunity is that family physicians and other primary care providers might be the only point of social contact for many older patients. Just as physicians screen for other risk factors, there might be a role for primary care physicians to identify patients who are isolated, lonely, and socially vulnerable, and to recommend evidence based interventions that could strengthen the social connection. So here we have Friedman and Nicole. They are clinicians in Ontario from Toronto. And so they too are saying, we think that there's a role for primary care to be part of helping patients and clients, because we might be the only and or the closest relationship or connection that someone might have to actually see how we can work together to improve this situation. So this takes us now to the actual project and the guidelines, a little bit about what we're doing, why we're doing, how we're doing, and what we hope it will achieve in this big complex world of health and social connections. So as mentioned, CCSMH has a 20-year history of researching and writing and mobilizing clinical guidelines. We share our website at the end, and there are guidelines, previous guidelines on delirium and depression, and several different guidelines on different substance use recommendations. And currently, in partnership with what we're doing right now, there are guidelines being written and launched this spring on anxiety as well as behaviors and depression in older adults. So you may find the website interesting from some of the previous work. All to say, we have embarked on researching writing clinical guidelines for healthcare and social service professionals. And to our knowledge, they are the first in the world. And we're very fortunate they were funded by an anonymous foundation who believes deeply in seeing what they can do to contribute to this topic. The potential benefits of clinical guidelines, primarily our audience are from professionals and clinicians. However, they are available to the public, so they are available to community-based organizations, to older adults and their families themselves, to younger adults and their families, so they are widely available. However, they are primarily written for clinical use. And you can see the list there. I won't read it all, but you can see it's really about quality, consistency, improving healthcare outcomes, informing public policy, calling attention to under-recognized health problems. So that's one of the things we hope for these guidelines. and also to identify populations within our population who may be at higher risk and need additional supports to bridge that health inequity. And I do note at the bottom that clinical guidelines can also have potential harm if they are not tailored to the unique context for patients and clients. They have to be used in partnership with patients and clients. They can't be used as here are the guidelines and you shall follow them all otherwise. No, they're very much intended to be recommendations, guidance to support clinical practice. Our methodology, very briefly, was, and this is typical for clinical guidelines, is that we recruited an incredible working group from across Canada. We carried out a scoping literature review, which looked at all the reviews of literature to see what's out there already. Are there any guidelines? And what we found so far is that there were no guidelines of this nature. So this is why we are feeling these are the first clinical guidelines on this topic in the world. So until someone phones us and say, we were number one, then we'll go to number two. But all to say, this is early research and early stages. We then facilitated 2 national surveys, which I'm going to share some of the results with you in a moment. And we also looked at promising practices. We had a chance to find out other things that were going on in research, but hadn't quite been solidified. We also brought in several other expert reviewers to look at our work because they hadn't been involved in it. So we were able to get some expert objective review and then a consensus decision by the working group. And now those guidelines are in translation in French and English and graphic design. And this is a slide of our incredible working group. So we have clinicians and academics from across Canada. And I just a little shout out to Dr. David Kahn. Dr. David Kahn was a founding member of CCSMH 20 years ago. He is a geriatric psychiatrist, and he is the chair of our working group. And he spends, when he's not working with us online, he spends his days at Baycrest Academy for Research and Evaluation Education that's in Ontario. So that's our working group. We feel very fortunate to have their contribution. So as I mentioned, we did 2 surveys, and we just want to share with you some of the results to see, and then we'll have a little bit of a quick reflection. So the first one was out to healthcare and social service providers across Canada. And what we learned from them was that well over 90% really felt they were knowledgeable about the physical health issues, they were knowledgeable about mental health issues, and they were knowledgeable about the social issues. High level of knowledge across a diversity of these professionals. Then we asked them, how do they feel about working and talking, addressing social isolation and loneliness as part of their practice? 70% felt it was well within the scope of their role to address issues. As well, close to 70% felt that it was part of their role to prevent it as well. And the kinds of things that they felt were in their role was supporting, observing, discussing, referring, and advocating. So 70% were feeling very strongly that it was part of their role. However, not everyone saw intervening and managing as part of their professional role. So we had some mixed reviews on their ability to address the issues. 45% felt that they could address physical issues resulting from social isolation. 55 felt they could address mental health issues, and 44 social issues. So what that's telling us that almost well over 50% of healthcare and social service providers feel like they are not able to proactively address these different issues. We asked them what were their barriers. 75% felt that there was a lack of community resources. 85% felt insufficient system or organizational funding to put appropriate interventions into place. And 52%, just over half, felt that lack of organizational or administrative support was impacting their ability. So we can see that they'd been thinking about it and they had some very clear information. What we have also learned since that 75% said lack of community resources. However, what we're learning is that it might be that there's a gap in their knowledge of the community resources that are available to them in their local area, because and looking at the community-based organizations, we are hearing that they feel we have programs, services, supports, et cetera, but the healthcare system is not knowing that we're here. So part of what we've been learning is that gap that seems to be existing, and there's some very interesting initiatives that are underway, such as social prescribing, that are trying to bridge that gap. We asked them the kinds of things that they were doing, act proactively. One was that they were recommending befriending interventions for their clients or patients. They were recommending physical activity interventions that could be group-based, or they could be exercising alone on your own. And then age-friendly healthcare, which is pretty big. And that's things like having extra time for appointments, having some flexible appointment modalities. Not everybody's comfortable doing a Zoom health appointment, but they might be comfortable doing a phone health appointment. And then that idea of bringing wraparound teams, having a social worker that might be in a session with a family practitioner. So these are the kinds of things that the practitioners felt would be helpful. And they did confirm, validate, identify for us that having clinical practice guidelines would be a very helpful support to them. So we're really pleased to hear that, and we're really excited as we move into the launch and mobilization of the interest. Now let's turn to the other side of the partnership and the older adults. So we facilitated a national survey of adults 65 years plus, and we were really pleased that over 1,800 responded. Do have to make a note, though, it was a virtual survey, and there was some hard copy surveys that were taken out to some community events where people were able to do hard copy responses. But we do know that we are missing the voices of people who are not either online or comfortable being online. And so that's, again, definitely a piece of work that we still need to do. So let's just take a look at some of the results of the older adult survey. So it really, very inspiring that over 90% of the respondents said that they were very aware not only of the mental health impacts, but the physical health impacts as well. So very high level of knowledge. But as I mentioned, we were surveying people that were already hooked online, so might have access to different resources. So that there's still a gap in learning what people who aren't digitally engaged might be feeling or knowing. And then interestingly enough, more than half of the respondents, 53%, said they were comfortable or somewhat comfortable talking to their health professional about feeling lonely or isolated. However, what we also heard was that 1 in 5 said they were uncomfortable or not comfortable and talking to their health professional. And so we asked them, well, what's getting in the way? What are some of the reasons? The top was I would be embarrassed, which speaks to sort of societal norms and how we talk about things. My provider does not have enough time. I'm only allowed one issue per appointment, which speaks to some structural changes. I don't think I don't think actually my screen is covering this. Whoops, sorry. I don't sorry, going backwards. Oh, there we go. It's not important enough to concern me, which again is on ourselves, and I don't think it's important for the provider. So you can see that there's some really interesting things coming out of what's keeping us from bringing this topic forward. Some might be on us, and some are definitely on the systems themselves. We asked older adults what would they be looking to from care providers, and building on the list that you've just started, providing me with some resources, connecting me to community supports, and suggesting activities that might help. We asked older adults in the survey what were the kinds of things that they found were helpful for them, spending time in person, appreciating that the in person has greater meaning now than ever before, exercising, or taking part in an exercise class, and using technology to connect with friends and family. 1 in 6 older adults, though, as I mentioned before, said they would talk to their healthcare and social provider about this. That's not a very big percentage. So what we are learning from this is that there's a certain percentage of the population that feels comfortable, will do it, self-advocate, etc., and that there's a very high percentage of older adults who are still not in a place of either thinking about thinking they could or should, or feel comfortable bringing the topic to their health provider. Our guidelines that I've talked about will be launching the week of February 26th in French and English. They will be publicly on our website and will cover the areas of, in addition to the background methodology and references, there will be 17 recommendations that are aligned to the areas of prevention, screening, assessment, and interventions. And I can't sneak peek any of the recommendations because they will be launching in next month. But one of the things that is embedded in these guidelines are that the importance of taking an individual approach with shared decision making with a professional and older adult patient or client, working to identify people's interests, their interests, whether current or future or past. So whatever actions are helping to build on interests, recognizing the diversity within all adult populations, and then appreciating that there are populations within populations as a result of health inequities that need additional supports, attention, and investment. And appreciating these are the first guidelines in the world. However, we are in very early days and much more work is needed. This slide is just really interesting. This is the national differences of self-reported loneliness among older adults. Unfortunately, Canada's not on this, but you can see that Greece is at the top and Denmark is at the bottom. So we could probably spend at least a couple hours talking about why we think this is. We don't know why it is. We just found this was a very interesting slide. Some research did to see the differences between countries. You don't know whether it's south of the equator, north of the equator, language, who knows. But anyway, just thought that was an interesting slide that I shared with you. A couple other examples, if this is an area that interests you, is that really the kickstart for making this very public was from the UK in 2018 when they announced a minister of loneliness and leading to their campaign to end loneliness. That's 2018 pre-pandemic. Japan in 21 also started to look at ministries of loneliness. I kind of like the idea of ministries because that crosses all of those social determinants of health. That was in 21, sort of coming mid-pandemic. Australia has an initiative very similar, Ending Loneliness Together. In fall of 2023, the US got on board and their Surgeon General basically announced this as a health if epidemic, if not pandemic, epidemic. And he's been a real champion for this prior to this announcement, but he's definitely in a very important position of influence and power to move this agenda forward in the US. The World Health Organization has their Decade of Healthy Aging, where they have named social isolation and loneliness as a growing public health policy concern. And we're just in the early years of that campaign. And then when I come to Canada, I apologize on behalf of Canada that Dr. Kiffer Card, who is being very connected with our project, and his colleague Kirk Hepburn, they have been doing some research to see what's actually happening in Canada. So our federal government has no national strategy or policies to address loneliness specifically. However, what we're learning is that, and maybe it's a Canadian thing, we're very grassroots. There's a lot of work happening locally in networks and organizations like the ones that you're affiliated with, locally, regionally, provincially. There are a number of initiatives happening on social prescribing. And then there are national nonprofits that are really focusing on this, including the Canadian Institute on Social Prescribing, the Canadian Association of Social Workers. So it's interesting. It's not coming top down politically right now, but there is a lot of energy and a lot of activity and some significant investments in Canada. So we'll cross our fingers that it'll all get pulled together. In grocery stores, there's some cool initiatives happening where they have a slower counter where you can chat with your cashier. Love that. So in summary, growing awareness, happening rapidly post-COVID. More research is underway and more is needed. It's really complex. There are important roles for healthcare and social service providers to be part of this system. However, it has to be done thoughtfully. It has to be done collaboratively. So we're not just piling more and more on a system and professionals who are working so hard, and yet there aren't enough hours in the day and there aren't enough of them to do what they're already doing. and just recognizing that we need to be spending attention on populations who have been and continue to experience health inequities. And CCSMH is continuing to work in collaboration with everyone who wants to be collaborated with. And in closing, not everything that's faced can be changed, but nothing can be changed until it's faced. So we're hoping you're leaving today with more information about this topic, and so that as we move into future conversations and potentially future work in this area, that we all can be coming from a similar foundation and a similar places of knowledge, so we can share our lived experience and insights. And there's our, you can go to our website, ccsmh.ca. You can subscribe to our newsletter, and then you'll automatically get the guidelines. There's a QR code, and I mentioned our website. So there we go.
And okay, so now that these guidelines are being put into place, are the guidelines going to have recommendations that go along with them?
Yeah, that's what guidelines really are. They are a series of recommendations for clinicians, so they can have at their fingertips all the best research and evidence to say what I could or should be doing in this situation with my client based on what kinds of health or social things they're bringing to me or that we're discovering together. So they are in the form of recommendations. And in this case, there are 17 recommendations that are related to some prevention, some around screening and assessment, and also interventions.
Okay. You know, someone just put in the chat that there's an, you know, maybe an assumption made that people have access to a family doctor or healthcare team. What would you say to that? Like, how do we discuss this issue?
Yeah.
You know?
Yeah, I mean, no matter where we go in Canada, having access to primary care is a significant challenge. So we are aware of that. We are aware of the sensitivities of that. So I think from where we're the perspective, the more people, individuals that know it, the more healthcare professionals that know it, the more social service professionals that are aware of it. Potentially, we can have conversations without 100% having to rely on having a family practice doctor, because that we appreciate too many people don't have that. But the idea that there could be other people that we can start the conversation with, and sometimes just talking about things can start to help us think differently about something. So that's there's no solution, and there's no recommendation about what to do if you don't have one. But the idea is making people more aware of it. As I go back to the UK campaign to end loneliness, you know, that just became so mainstream that, you know, it was something, it was destigmatizing, for one thing, is to recognize that we can maybe have conversations about this, and it might be with a friend or a family member. Or I noticed that someone said they were going to talk to their children in the chat. So again, those might be some other ways to help manage when we can't access that person, that clinician. One other thing I will mention is that part and parcel of the guidelines come out, and then we've got a couple tools. They're called knowledge translation tools, which is trying to take some of the maybe clinical information and putting it into more accessible form for everybody. And one of our kind of key pieces with this project will be an outward-facing pamphlet for older adults that could be in community centers, could be in doctors' offices, could be at pharmacy desks, et cetera. So that's kind of a major piece of this project, that we also want to get information out to older adults and their families, and communities and other professionals that are out and about in the community. So that will be another piece that we'll also get to you as well.
Excellent. That'll be a great resource for us as well. So thank you everyone for being here with us this morning. We hope you'll share with someone else what you've learned here today. Thank you again to the SHARP coordinators and to Shannon for your technical support. And on behalf of everyone, a huge thank you to Bette Watson-Borg for your excellent presentation and shared insights about bridging the loneliness gap, and the guidelines that the Canadian Coalition for Seniors Mental Health is going to be putting out soon. Take care, everyone. Bye.